Good afternoon, everybody. I wanted to start out by saying that we're talking about MS services, the future, Martin and I. Do you want to introduce yourself as well, Martin?
Yeah, I just pot around the NHS, interfering in other organisations and people's lives without any accountability or responsibility. I spent 18 years at the King's Fund setting up the systems group, and I'm opinionated.
And I pot around trying to help people to change services. So I thought I'd start out saying the future is not a destination. This destination here, I'd like to say it's my house in Josselin. I've just come back from France for this meeting. It's actually the chateau in the village where I live. My house is much more modest, but it's quite a nice place to visit if anybody wants to go there. But in terms of the future of MS services, the future is not a destination. It's a bit more like Ramesses. It's something that we need to imagine, plan, design and build. And I think even like Ramesses is 3,000 years old, we're always continually having to build and shape services and remodel them to take account of the changes within the system. So Martin's going to give us some context first before I move on to talking about MS services themselves. So I'll dip out here.
In my experience, an awful lot of clinicians who are trying to redesign services think that good ideas are helpful. And my experience is that most of them are awful. And the reason is part of the idea and the ideology in the world we work in. So the NHS, England, still talks a lot about change, transformation, things like that. I think are incredibly unhelpful ideas. Change things, you've got to give things up. Transformation's entirely mechanistic. So the culture and the words that are used around it, I think, put people in the wrong tracks. And I think if we think of the NHS as a system, a living system, the key bit to remember is systems only adapt to a change in the environment. Darwin's finches didn't say, oh, I fancy this year thick beaks are the really fashion accessory, let's get thick beaks. The food sources changed and they adapted. Their beaks changed and the rest of the finch was perfectly unchanged, etc. So until the ideas of the ways you want to change aren't genuinely tuned in to why the world's changed around us, then they're not going to work. And I think we don't pay enough attention to the changes that have happened in the world around us. And the obvious one is a changing pattern of disease. So in this room, we all know, what did people die of 100 years ago? Infectious diseases, isn't it? Exactly 100 years ago, isn't it? Spanish flu killed between 50 and 100 million people. More people than have died in every war ever fought in human history. And the pattern of disease has changed from infectious diseases, where nurses were incredibly brave, they held people's hands and caught infectious diseases themselves and died along with the patients. Doctors were no different from witch doctors in terms of their efficacy, and by and large health services contributed nothing to lifestyle. But when the NHS was set up, all of a sudden we had a bit of science behind medicine, and for the first time we could fix things. And notice, not an accident, it was fixing things. You had an infection, you got an antibiotic, you were fixed. For the first time, you could reliably survive being tortured, going to hospital and operated on, and things got fixed. And it's noticed in today's world how bonkers the WHO definition of health is, isn't it? A state of complete physical, mental, and social well-being. Who works in the NHS who's not sick then? This is completely... And what happens is now we know the only thing that matters are things that don't go away, long-term conditions. The evidence is really clear. The number of people using the NHS has not risen. It's failure demand. The same people are coming back again and again and again and not being well treated. And one of the best examples, and this is a big challenge to a specialty like yours, is not only long-term conditions, which you have to organize completely differently around, but equally the rise of comorbidities. So at current data for England, I don't know if it's, I assume the same will hold for Scotland and Wales and that kind of stuff, is 35% of people in your hospital every single day have 5 or more comorbidities, and over 75% of people in hospital have 2 comorbidities. How you organize to treat people with comorbidities is completely different from how. Seeing specialists sequentially is a complete waste of time and money and terribly ineffective. You have to start doing simultaneously. So the challenge for NHS is to respond to the changing pattern of disease. And we know we've got far better definitions of health, the hubris stuff, etc., which is absolutely the kind of which MS is going for. How do you increase people's capacity to adapt in the face of social, physical, and emotional challenges? The second thing we've got to face up to is who does what where has changed dramatically. So this is work done by the States, etc., where they start to look at, you should only be in hospital, really, if they're experimenting on you. I.e., in the really nicest sense, we don't know what to do. So we need you in hospital to do things. Things that are empirical, that we're extremely likely to survive. Doctors shouldn't be anywhere near. Nurses should be providing chemotherapy in people's homes. You shouldn't be in hospital for chemotherapy at all. And where you absolutely know the cause and effect, precision stuff, we waste a fortune and ruin lots of people, that make damage to the world by GPs prescribing antibiotics, don't we? Because they're terrified, they want to get rid of the person because otherwise they're going to be there too long. They don't want to annoy them because otherwise they lose them off their list and lose their income. So we hopelessly overprescribe antibiotics. Whereas if pharmacists had to prescribe antibiotics, you wouldn't have any of the same problems whatsoever. You shouldn't be going anywhere near doctors or nurses for this kind of stuff. But the challenge for us as the MS service people in the future is personalized. When you need things, it's unique to each individual. Then we have to organize differently. How we see citizens or people with MS as actual partners in the delivery of healthcare services is absolutely fundamental to the way we've got to go forward. So at the moment, for many NHS services, the professionals are the problem. They don't want to let go of who does what where and start to look at different ideas. And there's just so much of this. It's just unacceptable in today's world. And the best example in the UK, of course, is anaesthetics, isn't it? The biggest group of doctors in any particular hospital are anaesthetists. And if you go to the States, over half of what they do is done by nurse anaesthetists. Will they let them anywhere near it? You have to be joking. Dentistry's had 30 years of experiments of dental assistants getting better outcomes doing fillings, and every single year the British Dental Association says we need more data. They've run the same trial every year for 30-odd years, same result every year. Oh no, we can't let go. So these are things we've got to start to think around, and particularly I noticed one of the earlier questions is technology, and how we use technology to enhance relationships, not technology as a substitute or mechanization of things we're doing existently. And places like MIT, New Media Labs, etc., are doing some phenomenally exciting stuff around it. But if you look at the data from Intermountain, from the NHS, from the Cabinet Office, the current estimates are 60% of all NHS expenditure is waste. Failure demand, whole range of other things. The biggest source of resource and resourcefulness for any service going into the future are patients themselves, citizens, their families, and other people. So when we start to redesign services, we have to take notice of the changing environment. Absolutely embrace technology, rethink who does what where, and absolutely design around a different way of organizing in order to work with people. And we'll talk more about that in this hubs and spokes and networks.
So I need to tell you that if you want to ask a question or make a comment, you've got to go into the room for our presentation. So if you've not logged into the room, please do so now. So where is MS in the wider context of the NHS? Well, actually, it's only a drip in the ocean in comparison to all the other diseases that are there, the diabetes and the cardiovascular diseases. But I think it's a really useful disease to model integrated care, and I think that that's how we could well get onto the agenda at the moment in terms of service provision. But we are now part of implementing the long-term plan, lots of new policy coming out in relation to that. As an NHS, we are looking to try and lower the costs of the services that we're delivering, against the rising demand for services and drugs. We're looking at demand for more multi-sector partnerships, and we've got integrated care services coming online now through the sustainability and transformation partnerships. And I think it's really important to recognise the way that services are being delivered at the moment in order to be able to integrate MS services within there. There is the emergence of innovation, and we've had lots mentioned about digital technology, and we'll go on and mention more about that. But there is a real need to look at variation and standardisation, and with the right care and GIRFT programmes, I think it's coming more and more onto the agenda, neurology, more so than it has been ever before. I think there's a real shift in the way neurology services are being looked at the moment. Just in terms of neurology outcomes, in comparison to the general population, we're not doing as well as we could do. If you look at the number of bed days that have been recorded for patients with a neurological condition, 12 million, nearly 13 million bed days. That's an 8% increase in the 5 years since it was first recorded. This is data from the Neurological Alliance that was published earlier this year. If we look at the average length of stay, it's nearly 10 days in comparison to an average length of stay for the general population of 7 days. And if you look at mortality, there's been an increase in neurological deaths, 39%, compared to a 6% decrease from other deaths associated in the general population. And in terms of where MS services are delivered, this is a map of the types of centres where we have MS patients being admitted and seen and diagnosed. We've got neuroscience centres, we've got neurology centres that have got inpatients, we've got district general hospitals without inpatients, and then we've got district general hospitals where we've got visiting neurologists. So there isn't just one model at the moment where we can say this is the template for all services to be delivered. So it's really difficult to try and get some standardisation of the way that services are going to be delivered to patients with MS. So hopefully, if Slido is working, and it's not, can we ask you to put your hand up if you work in a hub and a spoke model of services at the moment? Can we have a gaze on the horizon and see? So probably less than about a third of the room are working in a hub and spoke. So, okay, so I wanted you to vote if you could on the poll and say whether you feel that the hub and spoke model that you're working in works very efficiently, it doesn't work at all, or whether you've no idea how a hub and spoke model works. So can we do that, Sarah? Yeah. Hopefully we'll get an answer. Some indecision here. Let's make your mind up time. So we've got a 50, 45, 42 split here. Roughly.
The trouble, of course, is interpreting whether you're a hub or a spoke in that. Because clearly, if you're a hub, you might decide it works really well. If you're a spoke, you might decide not. So it's really hard to interpret that. So I'd be really interested in the ones who didn't work well here. How many of you are spokes?
Well, we're supposed to be a spoke, but historically our neurologists work with London, but East of England say we should be working with Admirals. So nobody is helping us be a spoke with anybody.
Sorry.
So that's what
that's the same as Colchester with Malmö, they're linked with that. Sorry, I'm from Colchester, so we're now merged with Ipswich. We had historic links with Barts, and we're going to Barts, so
yeah.
But it's all confusing.
So, yeah, some interesting dilemmas here. So, interestingly, I've put up Adam Brooks as an example of a hub and spoke, but I think in terms of working as a hub and spoke, it is really difficult because we've got different geographies and different models and ways of working. We've got different regions. We've actually got 42 different mini NHSs now with the Sustainability and Transformation Partnership. So we don't have one overall NHS. We've got 42 different STPs that are working with different problems and different requirements of their populations. And I think that that's right, because not everybody's population is the same. And we've got acute neurology linked to medical takes, and we've got MS working within general neurology. So we can't just look at trusts in isolation. We need to look at each region and each trust individually and see how our model for people with MS fits into that, and bear in mind the local variations that there are. And I would suggest that rather than working in a hub and a spoke model, perhaps what we need to do is think more about a network and be able to network more efficiently with the people that we work with. And so Martin's going to continue here.
Just a quick input around, I think ideas really matter when you're trying to redesign services. And we'll share some other thing around what a model of care is. But I think the trouble is lots of people think networks are just nice. etc. Let's go for a network because it's a soft, woolly way. Economics is one of those particularly dismal subjects, but there's a fabulous paper in it by 2 Scandinavian economists. And they show that there are only 3 ways in the world you can add value. So remember, all organizations only exist to add value to the owners. The family owes value to you as family holders, and the NHS is here to add value to us as a population. And there are only 3 ways you can do it. The first way is through value chains. This is the kind of stuff that Michael Porter talks about, that the NHS bonkersly adopted very enthusiastically for a while. And what happens in a value chain, you add value by bringing together things to make something new or fixing broken things. So car manufacturing, restaurants are all value chains. And the only part of healthcare that's a value chain is elective surgery. And what you want to do is organize as a bureaucratic hierarchy, and your efficiency depends if you've got the right kit and the right process. And you organize then as a bureaucratic hierarchy. Unfortunately, big organizations, governments, picked up some of the ideas how to organize from organizations like the church and the army, etc., as a bureaucratic hierarchy. And in the early days in hospitals, of course, the dominant medics were surgeons. So the model of a bureaucratic hierarchy has fallen into place in most hospitals. And it's a brilliant way of adding value for chains, for things that are broken that you're going to fix, but it's a disastrous way of organizing for almost anything else. The second way of organizing that adds value is when you solve unstructured problems. In health services, we call this diagnosis, etc. And the way you solve unstructured problems is you have your brightest and best at the front line with access to all the best possible diagnostics. So if you've got a company you're trying to market, getting Saatchi himself with his ways of segmenting the market, or how you win an election, getting those people there is brilliant. And clearly, clinically, this is diagnosis. And how you organize for that, you don't pay people by time, you know, a whole range of different ways you do things differently. It's only around the quality of the diagnosis. And how do you get the best diagnostic kit and the brightest at the best at the front line is the best solution. This is why A&E is a basket case, because we have triage. Triage creates all the delays and oscillations and overshoots in A&E, because you're not seeing the brightest and the best. You go into a GP, you see a GP, the brightest and the best and the prime generalist, and the more diagnostics we give them, the better they'll do. You go into A&E and you bounce around between a whole range of people at various levels, and it messes up the system. But the third way of adding value is when the person you're working with is part of the solution. Then you've got to organize as a network. Telephone companies are simply a network. They don't tell you how often you have to ring your mom and what you need to talk about. They simply connect you up to allow you to do it. And the moment you have a long-term condition, the patient, the person with condition, and their support networks are a fundamental part of this care. Because until they come to terms with it, until they modify the behavior, until they actually tell you what drugs they're really taking, because most of them are lying to you most of the time, and how they're behaving and all the other bits around it, there's no conceivable way you can deliver a decent service. So if you want to organize for anything that's going to be the people who are receiving the service are part of the solution, the only way you can do it is as a network. And the stuff around the old-fashioned hub and spoke, and I haven't worked with MS services before, but in other NHS services, the hub and spoke model, basically it's been a control. The bright, clever ones can do some things, and the people in the isolated ones can do less, and it's all completely bonkers. And these days, that idea of who does what where can change dramatically. And if we start to operate as a network, and networks operate off very, very, very different rules and principles, and we'll talk a bit about that later, we've got a complete different possibility of creating new models of care that have very, very, very different outcomes. But how you operate a network, we'll talk a bit in the workings, is very different from how you run a bureaucratic hierarchy.
I think that apparently we've got quite a few questions building up, so I don't know whether, Martin, you wanted to stay up here, but there is a comment. Gosh, I need specs.
The GP comment I'd love to pick up in a minute because it's got links quite powerfully to another slide around what a model of care is.
Okay. So we've actually got a question at the bottom about are there any GPs in the room? Have we got any GPs in the room? Put up your hand, GP. Is that one? Yes. One GP in this whole room. I would argue that we ought to have more, really, because GPs are primary care and they're the route into getting some of the problems solved. So, and then it says, are patients present as equal partners in the planning of innovations and service redesign? Do you all have patients as part of your service work that you're doing? Do you consult with patients? I know if you're in primary care now at the moment, quite a lot of patients are involved in all the primary care meetings.
And again, I'd really encourage us to think of which things do you want them to co-design versus which things you want them to co-deliver. That's a complete different step forward. There's a whole lot of stuff that's currently being done by professionals that can probably better be done by patients supporting other patients. And then that frees you up to do the stuff that only you can do in your high value in your training. This isn't instead, there's a ton of fabulous stuff you could be doing that really uses your skills at their highest end. And there's a whole lot of stuff where people using the service as partners with you in the delivery of the service, not just the design of the service, could make a massive difference both to the outcomes, etc. People, by and large, hate being recipients of things. People love that mutuality and reciprocity and being able to give as well as receive. And there's nothing worse than being dependent in a service, particularly if it's over the rest of your lifetime. And that ability of patients to give as well as take, to be partners in the research you'll get out of wearables, the research you'll be able to do with patients live contributing, 100,000 patients in the UK contributing to your research would be phenomenal. Really, really raises and transforms the game overnight. But instead of just getting their good advice, I'm not suggesting MS services, but we know lots of other services in the NHS. It's this token consultation, token participation, asking a few ideas and the things that don't matter. And it's pretty grim.
So we've got a question there that says, can you overlap hub and spoke so that there are more choices and more capacity in the system? So I don't know this. Does anybody overlap their hubs and spokes that are working in hubs and spokes at the moment to bring capacity? One example might be in terms of nurse specialist support when nurses are on holiday, that type of thing. I know waiting lists build up and clinics get cancelled. Is there any way of doing reciprocal arrangements in terms of seeing patients? Karen has put her hand up here. The mic is winging its way towards you.
Yeah, we try and operate a hub and spoke, and so the nurses are supposed to cover all the hospitals that we cover over Greater Manchester and East Cheshire. On paper, it's excellent. The theory is the different digital systems, and actually it's another hurdle. So you've sometimes got the manpower and not the digital systems, or sometimes you've got the digital systems and not the manpower. So actually, if you have the two, we would be able to do it better than what we could at the moment. So it's a challenge as well, because the different, just the whole different structure of clinic setup and the levels of nursing. So we do try and do that and provide an equitable service, but invariably, as soon as someone goes off sick, everyone else's workload goes up, and perhaps the quality isn't as good as what it could be.
Yeah.
So getting the systems to all talk to each other, absolutely essential. But there are also lots of really good fudges around. So you give people honorary contracts so they can get into your systems. Why can't you get an honorary contract with your GP so you can access their systems? And there's a whole lot of stuff there that we can get decent fudge around. And we also know that almost every single patient we've ever worked with, they give permission to use to WhatsApp pictures of their data to anyone else there. Their concerns about this data security and the confidentiality, when it's for a particular case, non-existent. They absolutely trust you. Say, take a picture of me record and WhatsApp it straight to the person there, and they're very, very happy. So you can get consent for a whole range of other things. I'm not suggesting the system isn't making it ridiculously difficult at the moment, but there are ways around it, and how do we get, particularly the SDPs, I work with the SDPs and the chief execs, etc., until they understand that the first thing they've got to do is get all their IT people to start getting these systems to talk to each other. And everywhere in the country, part of it's been done. So this isn't a technical problem, it's entirely a will question. And the more pressure you put on them, the more likely it goes up the agenda.
I think Gavin wants to say something.
I just asked Caroline how many hubs is she plugged into. She's plugged into about 3 or 4, but she's doing that herself. It's not like it's a empowered individual who's doing that. It's not like everybody with MS can plug themselves into multiple hubs. So there is overlap, but it's up to the individual to do. It's not the system that's doing it.
Absolutely, but you can lead and get change. In the future, when you need radiology and that kind of stuff, there'll be just anywhere around the world will answer in real time. You'll get your reading within 15 minutes of any image being done. It's absolutely crazy to sit here waiting to get results back for anything more. There'll be a network of people who are accredited, and will be in the same way you can start managing each other's overload and capacity through different kinds of relationships with each other. That's when someone needs your particular expertise. On the Western Isles, they can tap into your expertise for the 15 minutes they need it, and equally, between each other, you'll create different kinds of networks. So you'll have very strong, powerful local networks, and you'll have weaker, different kinds of connections at different places. But there's certain things that probably the people in the room who's simply the best person probably in the world to answer it. Why not get them to answer that?
There's another comment there. Don't networks just turn into an informal who knows who and who lives where arrangement, developing echo chambers of variable quality outcomes?
Only when we use networks in the way that we sometimes use it as just to think of our social group of friends. Networks is a very precise but very, very different technology. So you have the same feedback loops. In fact, the better networks have far better feedback loops and far better sanctions. All of you know that if you invite someone for dinner 10 times in a row and they never invite you back, you stop inviting them. And I invite me for dinner and I'm sick all over your house, you don't invite me again, etc. And my reputation spreads. So networks are very, very powerful as a way of getting high-level coordinated behavior. Your reputation is one of your key currencies in a network. And there's reciprocity. So if you all take, and no matter how big a professor you are, you can't ask for help in research unless you're prepared to respond to requests back. If you only take and never give in a network, you die instantly. Networks are an incredibly powerful way of coordinating high standards if everyone signed into the principle and you've got those feedback loops. I'd really encourage you not to think of them as soft and wishy-washy. Very, very powerful way of organizing and connecting.
So I'm going to move on to talk about population healthcare. And I think this is a really good idea because it could ensure that everybody with MS gets really high personal value by providing them with information about the risks and benefits of living with MS, and it can also help to shift resources from one patient to another where there's overuse or low value of some of the support that we're giving to patients. I think it's, in terms of the job that I do, we see a lot of patients that are going into to you in your different services to receive disease-modifying therapy. But there are a lot of patients out there that perhaps aren't on therapies, or they are, we've got progressive treatments now, but secondary progressive MS. These are the patients that are out in the population that perhaps aren't in regular contact with the MS service, and they're not receiving support. And many of these are the patients that are the ones that are going into hospital with crisis. And so I think that there really needs to be a stronger look at the population healthcare and trying to identify all of the people with MS within a given area and try and address some of their needs as part of that total population. And looking at the variance in services at the moment, there's a poster next door that we've put together from my analyst team looking at the variation in the number of admissions of people with multiple sclerosis into hospital. So on the right-hand side, we've got all the different STPs in England listed there, and you'll see by the colour of the map, this is weighted data, so it's by 100,000 population, but by the different colours on the map, you'll see the different numbers of patients that are actually being admitted into hospital with MS. It's quite variable. Yes?
I was rather surprised that we put Wilmington, Bedford, and Luton together. The three of them has got different service provision altogether.
Yeah.
I am a little bit confused in your decision to put three in one place. Bedford has got one neurologist and nobody else. Milton Keynes has got neurologists and nurses. They don't deliver full service. And Luton has got neurologists, MS nurses, and they deliver full DMTs. So I'm a bit confused why you picked up in the way you did it.
It's just the way the maps develop through with the STPs. It's not something that's been done consciously.
I fully appreciate that is the case. However, as it doesn't reflect the service provision from each hospital. They haven't joined yet. They've got no interaction with each other. So I think it gives the wrong information, basically, in my opinion. It certainly doesn't reflect what the practice is. So
Okay.
I would challenge you on what you produce there being accurate or not.
Okay, well, this is just NHS digital HES data in terms of hospital admissions, so that's, you know, the return that's been on the data. It's really just to try and illustrate the variation that exists, but I accept that it may not be reflective of what you think should be the case, but this is the way that the data has been developed from NHS digital and the number of admissions that are there.
I fully accept what you're saying. However, if my area is that wrong, it's certainly the whole data, I would say, is questionable.
Okay.
So is it really worthwhile producing the data if it's not accurate? That's my question.
Might be accurate, but you do assume the causality is because of your service. We're not saying that at all. We're just saying this is the number of people who are admitted with MS in this area. We're not saying which service is responsible or why or anything like that, but that actually is the number in that geographic area with those postcodes of people who are being admitted. We're not saying anything about causality.
I will discuss this outside. I don't think it's worth continuing in here.
So the point, I can speak to you separately,
I am passionate
Hussein.
about this. It is a wrong data. You're telling me that Milton Keynes, Bedford and Luton, you put them together. I know Luton admission rate, and it doesn't reflect that. So you can't tell me that because STPO, you're going to clump them together. It doesn't reflect the reality. So how many times do I have to repeat myself?
Okay, I'll speak to you separately about it. But it's really to show the variation in the way that services are being delivered at the moment. And my whole point of this was what would be really nice is if the map was just all one colour and that everybody was getting the same service. But I will pass over to Martin to talk a little bit more about getting the best out of networks.
Yes. So this links to the question around are networks warm and fuzzy and entirely dependent on colluding, you know, the lowest or highest possible standards depending on the relationship. And to say, I'd encourage you to think of networks that are work nets. You do your work through being connected. And how you become more integrated. So it's not that one parent does all the punishing and one parent does all the praising. How do you get a system there that you get the right response from whoever's in the right person by being connected to each other? So they're really, really powerful ways of formalizing, but do notice that reputation is one of the key currencies and that reciprocity is the basis. And that's why it's so beautiful for a service like MS, that you're actually small enough to know and care about each other, where reputation really, really matters, and reciprocity is something that actually is meaningful in your relationships with each other. That the only way I can do my research, develop my stuff in this part of England is by being connected and supported by people across the country, doing the research we want or getting the data we want. You're saying, oh, we're going to need really high quality data before we can do that. How do we mobilize the entire system to get that data within 6 months rather than the traditional 4 years that it would take? So I'd really encourage you to think that networks just a different way of working that isn't the way that often many of you know in your personal relationships or one or two relationships. The question is, how do we scale this up to make it good for all people who have MS and all people working for the service? Because the beauty of a network is it has to work for both parties. It has to work for the people delivering the service as well as the people receiving the service. It's really, really fundamental. And I think the challenge for many of us then becomes, how do we move from our history of and tradition of belonging to an organization to shifting to our behavior that focused on how do we get service and the outcome for the patient. And by and large, overwhelmingly, if you look at the SDPs and the fights that they're having in the bun fight over, you know, redesign of service and who does what and who's taking control of things, it's overwhelmingly focused on specialties fighting for their own space, institutions fight, the acute hospitals having this fight to the death over which services get where and how they control it and this kind of stuff, instead of shifting to the functions and the work units, not your history and place. So I'd really encourage you, this is the real challenge, one of the big challenges for the future leadership of the MS services, is how do you move out of organizational focus and into service focus?
Because
Sure.
we're getting hundreds.
Okay, this is around the GPs and their problems and some of the questions there. So I'd encourage you to think of a model of care. Historically, we've described models of care as either secondary or primary care or nurse-led or consultant-led. We've seen it as roles or services. And this way of seeing a service, this is a systems model of care, which says all services have to provide reassurance, advice, routing, assessment, diagnosis, transport, provision, intervention, coordination. And this holds for all levels of the service. So what happens is GPs often send patients to hospital because they're not getting the reassurance and advice that they need. So we did some work, for example, in West London with Altogether Better, where we had paediatricians go out into general practice, did a joint session with the GPs. Within 3 months, they had reduced secondary care referrals by between 60 and 80%. Because all of a sudden they'd built a relationship. Most GPs are terrified of children because most of them haven't done pediatrics, and everyone knows children go off fast. So everyone in the systems needs reassurance, advice, knowledge, routing, and assessment. York A&E, asking patients why they were there, 80% were there for reassurance. You don't need to go to A&E for reassurance. We can create other systems. So I think this is the stuff is what we need to do is think is what is it reassurance and advice we have to provide for GPs so they can not just see the MS and be reassured and that they can manage things better in the community, the comorbidities in the community, and a whole range of other things. It's just crazy, the admissions that I gather from your data that you're getting for UTIs.
Can you explain work net?
Yeah, just think of it networks. So often we think of networks in terms of the social dimension of it. If you think of it doing your work through a net that works, a set of relationships that allows to get work done, not just to be friendly and connections. And that's a far more powerful way. You start to think of it as a far more formal and manageable system. So what you hold people accountable for in hierarchies or solution shops or diagnosis or for delivering care through a network is completely different. How you do strategy would be different. What the performance metrics would look like would be completely different. So it's a way of just thinking it in your head as it's a genuinely formal way of organizing. It's just different from the ones that most of us are used to. Formal service level agreements, I think we're probably in the room, there'll be lots of different opinions of it. My experience is service level agreements are simply the divorce documents, what you do in the break if the relationship breaks down. The moment you have to do is depend on the service level agreement, you've lost the relationship, and then it's beyond it. So I'm not suggesting you don't need some of those conversations to get a structure and a framework, but if you're relying on it to get the quality done, it's hopeless. But do understand you need it as part of the conversation, the scoping conversation. But the moment you're holding anyone to account contractually, you've lost it. Working as spoke, yep. So that I work in a spoke, we prefer it to be one team, one contract knowledge, both hub and spoke as one S team, absolutely. And I think that is the way forward to organize as a network, and which different nodes have specialties and which ones more you can push things to and stop thinking of it in terms of conditions. Think of a particular service. It's absolutely crazy that you can't do transfusion at certain places.
But how many people are actually liaising with their CCGs and actually talking to them and having joint meetings? That's the issue, isn't it? Because not necessarily are we engaging between secondary and primary care. Do people want to put their hands up if they know who their CCGs are and if they're talking to them? Only a smattering of hands.
Yeah. And I would encourage you to take Gavin's thing around coming up with solutions, not just problems. It's really fair. This is very part of the way British get things done as foreigners we would notice. Thatcher's famous quote, all my ministers bring me problems, Lord Young brings me solutions. He's my favourite minister. It's a long tradition in this country. I promise you, if you're in NHS England, you're CCG, you don't know what's going on at the best of times. Someone coming at another problem, you're just going to smile sweetly at them and ignore it. Etc. You're far too polite, you're all important, they don't do anything, but they just can't cope with it. So I'd really, is there evidence that patient involvement, it's just gone off there, I'd read it earlier, makes a difference to outcome? Absolutely. Tons of data, and actually if you look in the UK, I think it's Newcastle University, they've pulled together the data for people with long-term conditions. Their sense of well-being and outcome is completely uncorrelated to the medical markers. When they're participating and feel that they're in control and shaping their treatment, makes a massive difference in its own right, but overwhelmingly there's data, and we can talk outside and can point to articles and connections of the impact of people co-producing their care, making a big difference to outcome. And one of the good examples, if we've got a GP in the room, is Altogether Better will give lots and lots of examples of a massive reduction in use of general practice when citizens start to sort of meet the social and other needs of people on the list rather than have them go in under half-cocked medical pretenses.
Do you develop more MS networks within more traditional hub and spoke models, for example, acute neurology? I think you can, yes. I think it's, you all know each other, and I think it's easy to network around, and if you've already developed relationships.
I think one of your big challenges in the future is going to be with your other neurology colleagues. Yeah. And so, as I said, I haven't worked with MS before, but I've worked lots of other services that are neurology services, and the infighting between the different neurologists is far, far worse than the fighting across different specialties. It really, really is. Historically, in the neurology service I've worked in, so I'm not just generalizing it, it's awful. Get over yourselves and the things. And the second one is, I can't overemphasize the stuff around comorbidities. With comorbidities, you're going to have to start to make yourself available to see your patients simultaneously. So it might be through Skype these days, you don't have to be in the same room, but the outcome is completely different. Those hospitals that have stopped having any geriatric beds, for example, and the geriatricians run around the hospital, so every time the cardiologist seeing the geriatricians there, their length of stay is a third of the national average. Outcomes so much better, costs a fraction. Comorbidities is a really big challenge, and you're going to have to also work differently. So it's not just the how do you get your own services fabulous. The future involves you working differently with other neurologists as a voice, particularly across NHS England. You're just too small. Get out things, and actually how to work in comorbidity stuff is critical for the people you're serving.
We've got amazing interaction here. We've got questions queuing up by the ton, which is why I'm jumping up and down here. NHS England has reduced the number of prescribing centres to control spending.
Yeah. Tariff is a device. What happens is the government takes money highly appropriately out of all our pockets, has this pile out there, and it's got to give it out to you. So it invents tariff as a device to get money to the right places. So the Royal Free Hospital in London gets 23% more for everything it does, not because it actually costs anything more there, they've just got to cover the hospital's costs. If you get together collectively, you'll get the money you need out of the system, etc. Do not get overhooked, in my opinion, on just focusing on a tariff. Because as you say, some hospitals understand, oh, we've got the whole hospital's getting a load of money, etc. How do we just fund all this kind of stuff? So it's an internal battle, it's an external battle. Just fighting tariff is fighting a symptom, not a generator. You've got to waste your energy on the big questions, the underlying issues, not the symptoms. Tariff is a symptom. It's a symptom of the status of MS, a symptom of a whole range of things, a symptom of misunderstanding, a symptom of the transition of moving from surgery to long-term conditions. It's just part of a system in transition. You've got to have your voice heard in those conversations, absolutely, but it's not the real battle. So.
Were you nodding there, Jeremy, to say something?
Let's start by saying I'm opinionated about everything. It doesn't make me right. I'm not stupid on the things.
I note your comment about the importance of patient involvement.
Yep.
Clearly attractive to all of us, but is there evidence that it leads to better outcomes?
Absolutely.
Absolutely. Expert Patients Programme was a very good example of that.
Yeah.
Empowered patients.
Yeah. And it's a particular, I'm personally not in favour of expert patients sort of stuff as a divorce, because that's still that expertise is the solution. And you talked about stuff around holistic, and that's the real challenge. So there's a whole range of other things. Just, I think it's a very medical view of the world that more information is the answer. It really, really is for a long-term condition. And actually, you know with all the information they need to know. So they've got other information as well, and other things that they can bring that actually makes it around a more stable service.
Is there a high priority outcome from this meeting for us to describe how MS services are configured across the UK to understand causes of variance? I would say so. Yes, it would be very useful for us to do that, and then we can start to understand how we can improve the services that are being delivered at the moment. Yeah.
And that is those mental models of, the triple normal quality models of different kinds of variation, special variation versus normal variation. And you'll be able to show how your pattern of organizing determines the variation. The variation is systemic, it's not individual. Most clinicians are terrified initially about addressing variation because they're all worried they're either not as good as they are or everyone's going to be scared. And it turns out overwhelmingly. The data from the States is absolutely clear. I've taken the presidents of the Royal Colleges and study trips to the States to understand quality as a systemic phenomenon, etc. The variation is overwhelmingly systemic. It's not personal. You can relax into this. It's not about your personal competence. It's overwhelmingly systemic. You'll pick up in your entire system, there'll be one or two duff ones, big deal, you all knew that anyhow. Oh. Yeah.
So really the priorities around what's driving services now are these: integration, workforce, money and technology. And I think these are some of the things that we need to discuss over the next few days. But certainly we've got a lot of pressures on us. We've been hearing about workforce earlier. And I think there is an issue here in terms of we need more support, but not necessarily the same sort of support. I think one of the overwhelming requirements, having done the work on the disease, disease-modifying calculator, looking at how much time is being spent by nurses, particularly, and pharmacists around monitoring drugs, bringing people back for bloods, interpreting the results, and then communicating them back to the neurologist. There's a huge amount of time wasted, and I would urge you to look at Rachel's poster that's next door, and I would also urge you to actually use the calculator yourself and just work out how much time is being spent, because a lot of that time that's being spent by nurses and pharmacists could be done potentially by an administrator who would liaise with you and free up time for you to be able to see more patients. But integration is key on this, and the way to actually get that, I think, is through use of digital technology. We are using technology a lot more than we did do. There is all sorts of technology, though. There is technology to empower people, to support us as healthcare professionals, to make better use of our time, to look at supporting clinical care, to improving population health and improving clinical efficiency. So it's not just about apps and different devices. There's a whole range of different things that we could explore and start to look at. And these are the top 10 digital technologies that are projected to have impact on the NHS over the next 20 years or so. Telemedicine, smartphone apps, sensors and wearables, the genome, speech recognition, virtual and augmented reality, and artificial intelligence. There's a lot of stuff out there, and I think that we perhaps need to try and up the amount of technology that we are using at the moment. It's not that there is anything specific that I could promote, but that, there's lots of stuff out there at the moment, and perhaps we ought to be liaising a lot more with the medtech industry to design more useful pieces of information technology that we can utilise for our patients. We also need to start looking at the patient pathway and deciding what that patient pathway needs to look at and what's appropriate for our area. And again, we've done another poster here today. This is Rachel's story. It's looking at an optimal care pathway around disease-modifying therapy to look at the treatments and also the monitoring for that, and also patient choice. It's a fictitious scenario, but it's based on some storylines that we've done with patients and with a stakeholder group, similar to the right care methodology. But again, it's just trying to map out that patient journey and, what are the critical points within the journey that the patient wants and that the service needs to deliver, done on a financial cost model. A lot of the crisis support that patients get is the costly stuff that's part of that pathway. And again, it's something that we need to be thinking about, is the patient's comorbidities and how we can stop those from occurring. On an annual basis, I've been looking at emergency admissions in multiple sclerosis, and this is some of the data that I frequently show around what's happening. But if we start to unpick which patients are failing in the system, which ones are utilising emergency services more than others, and the reasons behind that, then I think we can really start to get to grips, again, looking at a value base for managing MS by addressing some of the problems that patients have, which tend to be, and I keep going on about this, UTIs, chest infections, basic requirements like constipation being managed appropriately. So if you can have a look at what's happening within your area and start to prioritise, those areas that perhaps do need a little bit more attention, that might be really helpful in terms of liaising with your CCGs. As leaders, it's knowing what to count that matters. So Martin's going to More
Is
questions.
Rachel a real person?
Is Rachel a real person? No, she's not a real person. She's a fictitious patient that we pulled together as a scenario using the right care methodology. But we did quite a lot of interviews with patients in the development of the storyline to ask them what the key issues were in terms of living with MS. And we did some consultation with Shift MS as well, but it's really a kind of a fictitious patient that we gave her all the problems that she might encounter and all the daily living activities and the pressures that she got in her social life to try and pull that storyline together. There is a poster next door about it, and you can read a little bit more about it if you wish during the course of the meeting.
Okay, yeah. Can a work net be established across multiple CCGs and STPs? Absolutely. And it won't be everything across the larger scale, but there's certain functions, absolutely. You've got friends in other countries that you ring up and ask for advice on, and you've got friends next door that helps you feed your cat when you're away. They just do different things. Not a problem in the slightest. Nervous managers, I really see your commissioners, I agree with your point there, as the partners in this. I hate the word personally because I'm a systems geek of co-production. But get your CCG people to come, go visit people with MS with you. Come see your service, spend a day watching what you're doing, etc. Then invite them in to be partners in designing what a new and better service will be. So don't treat them as these are people I've got. No one's ever got more money because they've had a good case. Every CCG is choosing between goods, all good choices. Every case makes a brilliant case for him. The choice isn't around, it's always between competing goods. It's not a good case or a bad case. They're all good. You need something else to get them there. Get them partners. Get them to go visit people with MS. See what their lives are like, what difference the treatment makes. Speak to the staff doing it. Come and spend a day watching you working your socks off. Then they'll be partners in you designing and paying for the right kind of stuff. Really, really easy. And the advice and guidance, etc., really is good that people have thought through and it's there. But no one looks at it because it's there. All of you know what the official guidance is around drinking alcohol. Does that change your behavior? You have to be joking. The fact that you know there's a gym down the road doesn't make you use it. Other things get you to use it. So it's good that it's there, but you've got to build some kind of relationship, some sense of feedback. When they're referring that are inappropriately or not, close the feedback loop. Be curious. Why did you refer this case in this particular? What was your anxiety that you couldn't manage it? Build that relationship, and then they'll start to use the guidance. But no one's going to use it just because it's on the internet. Madness. None of us do that in our own lives. Why expect other people to? So I'd really encourage you. It's really important that we have those things, but you need a relationship to get people then to use it. And if you give feedback to your people who are giving you referrals or saying the wrong things you want to use this, build that relationship, get things going. It will be very, very different. But I'd really encourage you to remember the metrics you choose are fateful. I'd encourage you to give an awful lot of thought to it because by and large, we come from a world of metrics of parts, not wholes. And parts and wholes are completely different. I can know everything about your endocrine system, your immune system, etc., etc. It doesn't tell me anything about you. Knowing you doesn't tell me anything about your family. Parts and wholes are completely different. And you always get what you measure. So I've got hundreds of these slides. This is Marks & Spencer, British Airways. Focus on profitability. You get your highest profits just before you go bankrupt. Guaranteed. You get what you want, but always at a cost. And I ran this is stuff you know, but when you show this to a normal, a non-clinical audience, they have no idea whatsoever. So I did this fabulous workshop where we had Ari Goldberger, the professor from Harvard, and the professor from Canfield here, who's into systems change and manufacturing, around what's the difference between metrics of wholes and metrics of parts. And I'm not suggesting you don't need a couple of metrics of parts, but if you're going to get metrics of the whole, of either the service as a whole or a person with MS in the holistic sense, those kind of metrics are non-stationary, non-linear, and multi-scale. So you're going to have to start to come up with different ways of measuring or creating metrics for your service as a whole. Don't fall back on parts. They will destroy you if you only get metrics of parts and you're trying to create a new model of service that's a very, very different whole. If you're trying to go for holistic care for the person's whole life impact, whole brain health, etc., you're going to need very, very different metrics from the parts. And you'll probably only need 1 or 2 or 3 wise ones. This is where my first degree was mathematics, and there was this branch of mathematics called methods. And the one professor said, for this branch, intelligence is no help whatsoever. You need low cunning. And to find metrics of wholes, you need low cunning, not brute intelligence. So using the story. So I'd really encourage you to take metrics incredibly seriously, but lead the way on the new kinds of metrics for the whole not just metrics of the parts. You'll need one or two of the parts, I'm not knocking them, but they will always distort. So, nope. The whole is complete. Someone in the room, whoever asked the question, imagine you're the world's greatest chemist. You won Nobel Prizes. You can know everything there is to know about hydrogen, everything there is to know about oxygen. It doesn't tell you anything about wetness, water quench, thirst quenching properties of water, any of the wholes and parts are completely different. I'm always in awe of who invented mayonnaise. How did someone work out that half of an egg, one part of an egg, plus oil at a certain temperature led to mayonnaise? Wholes have emergent properties that you can't know from the parts. So you just can't do it, saying as systems. It's for complex systems, for mechanistic systems, for cars, you can have metrics of each part, the tires, how well they're working, the battery, how well it's working, but wholes are completely different. Complex systems are completely different. So no. Yep, so one is you can either, how are we going to work this out together? These are the constraints in our system. Let's design a little system using where the efficiency drugs are. Second one is just ignore it. It's amazing what you can get away with if you ignore it. When you're trying to do, you never ask a question if you might not like the answer. So there's a whole lot of stuff you just get done and it becomes the I have the joy, so as I said, I just pop around the country. I work in Scotland, all over the country, etc. All the things that people swear blind are illegal and impossible in one part of the country, someone else has been doing for 5 years somewhere else. Just ignore it. Do the right stuff. That's the challenge. It's the Buddhist stuff. In designing services, you go for Buddhism. They talk about beyond hope and fear. The moment you've got hope, you've got concomitant fear that it might not work. Simply do the right thing. Go beyond hope.
Thank you. So we've got a question there that says, often the restrictions for speaking with our commissioners is a nervous manager.
That was my one.
If we highlight our services in any way, I will lose the funding. We've got commissioners and managers in the audience, haven't we? Can they answer this question? Will you cut funding? Where are our managers? Put your hand up, commissioners. I know we've got... Are they hiding? Julie there. Do you agree with that?
Not necessarily, no. I think it's about having open Thank you. Not necessarily. I think it's around having open communication with your commissioners and particularly what was just said before, inviting them in so that they can actually understand your services and work with you to develop them.
And in actual fact, we've recently set up, at Julie's request, a national manager and commissioner network for neurology. We've tried to do this before, and it's never worked. I think we've had about 15 people, but we ran the first meeting in May. We've got another one in September, and it was sold out. We had about 60 people who were managers and commissioners came, and that's the first ever. In my experience of like 40 years of working in the NHS. But it's the first time we've had that many managers that were managing and commissioning neurology services together. And Adrian Williams was part of that group, and Adrian's going to be chairing the next one. So the time is right, and let your managers know that we've now got this network to support them in terms of commissioning neurology services for the future. I think it'd be great to get them all on board. We kind of draw into a close in terms of the presentation. I think we've got loads of questions as well, but I just really wanted to kind of finish up by saying that what we really need to do in terms of our hub and spoke model, regardless of whatever we do for the future, is develop a population-based system that looks at all the needs of people with MS by ensuring that they're all being seen by specialists and having their condition monitored to get the best value for the service, to get the best outcomes for the patient, to make sure that we don't get all these problems that they seem to get. Gavin's put up there, he thinks it's a failure if we're not providing timely appointments. Oh, well, you had another one up there as well about UTIs.
By the way, the data is very, very clear. The people who frequent users of A&E are exactly the people who frequent users of general practice. It's not because they're not getting GP appointments. Yes, the fact is that over probably close to half the people the GPs are seeing, they don't need to be seeing. There's no benefit whatsoever they can get from going there, but it's not because of absence of GP appointments.
But Gavin had put up earlier that he thought it was a failure because admissions with UTIs, chest infections, falls and fractions, fecal impaction are to me an indicator of failure to manage MS appropriately.
Absolutely.
This is true, but I would say that a lot of these people may not be seeing neurologists at the moment. They may be patients that have been discharged, that are no longer on treatment and that are out there in the community under the care of their GP, but their GP doesn't know how to manage them either, so they seem to kind of fall into that gap, where they're not being supported. So these are the people that I'm suggesting in terms of the population that, we've got people that are receiving the specialist service, but there are also others that would benefit from the service. So we need to work out, which people we want the specialists to see, and we need to empower our GPs and our community staff to manage others that may not necessarily need specialist care at that point. So I think, for the future, we need to start looking at working as a network, and for us to work with primary care and in an integrated way so that we can do the best for all people with MS. And I just want to end with time is brain. This is from the international consensus guidelines and around that time frame for people being seen, diagnosed and treatment initiated. Wherever we're delaying seeing patients, we're actually in danger of not managing our patients in the best way possible and getting the best possible outcomes. So these are the things that we need to think about for the future in terms of the way we deliver our MS model. So I'll finish there. I think that's the last slide. We're on to discussion now, but we've got lots of questions there. So if Martin wants to... We've got what? 3 minutes before coffee break. Oh, right, okay. So,
again, in my experience, I'd encourage you to have your networks as personal as they possibly can be. Don't forget, one of the things about the NHS, this is one of the largest organizations in the world, but it's actually one of the most value-driven one. Almost all of you here put in way above what you're paid to do, etc. Who you are and how you are in this is a big part of your work. I'd really make those networks personal. And all of a sudden, when you're having awards, say, God, these are the people who respond really quickly. It's a currency. It is about you. You give so much to your work. I'd encourage you not to make them faceless in network. I think its power comes because of who you are. And actually, it's part of using yourself in this and getting the recognition of it. That, yes, I did help you out this time, and no, I get helped out as well. So it's not, I'm wonderful. This is the only way we are. We're in this together.
We've got lots of questions here and little time left now. What we're going to do is we're going to compile all the questions together and we're going to respond to those in the report that comes. So everybody's questions will get answered. It's just that we probably have now run out of time to answer everything. So I think have we got coffee now? Yes. So we've got coffee now. Thank you so much for being so interactive and keeping us dancing up and down here. Thank you.